It's at 8:30 on Friday, April 18th. We're listening to a couple amendments this morning, and we have an amendment on S27, introduced by Representative Donahue and others, and Representative Black. And Representative Donahue is going to present the amendment to us.
So everybody got it. I want to say, when I listened to the discussion with my prior amendment, one thing really struck me, because I was listening to all of the arguments about why it was important to have that term in the statute. And it was not persuading me, because I knew that factually they would not be able to get away with it. But one person mentioned, I can't remember who it was, doesn't matter, but about the fact that even if you can push back and get them ultimately or something like that, an individual isn't going to know that. And the difficulty of, you've got to actually pursue, challenge, etc. And I thought, yeah, I mean, that's an important point. That's an important aspect. So I was thinking about, how do we address it when the term was used in the discussion, outward facing, when it's something that is going to be interpreted and looked at by other states that use the term behavioral health, maybe meaning something broader than mental health and substance use disorders. So how could we make that explicit, that we do need to include this word in some statutes because of that, so that people can't have that loophole to say, well, it wasn't in your statute. So this language developed. It's really three sentences, and the first sentence is basically, generally defining the conditions that can be interpreted as part of behavioral health beyond mental health and substance use disorder. So it defines behavioral health that way, so covering that gap, basically. And then goes on to say, in our statutes, it doesn't include mental health conditions or substance use disorders, but that we recognize that it has a stigmatizing impact. It may deter individuals for seeking healthcare, but we also recognize that some jurisdictions interpret it to include those, and therefore it may be necessary under limited circumstances, but when to include that term in the definition for the sole reason of avoiding any questions about the intended scope. So if we, in the definition of healthcare services, use the term behavioral health meaning this, plus use the term, list also substance use and mental health conditions, we've covered everything. We've covered that potential gap by including the meaning of things that are beyond that sort of more common use and scope. So that was what it was put together to address, to have it on the record that it's not something that we think is a good idea to use in Vermont, but that we recognize that in some circumstances, if it's dealing with jurisdictions where they may have a broader use of the term, then we want to cover that gap and make it clear outside the state that we do mean all of that, and you can't claim, well, this is behavioral health, and you didn't include behavioral health in your statute, so we have a loophole. So that's the suggestion.
And I will just say, from my perspective, and I said this when Representative Donahue presented her last amendment, that I absolutely recognize that for many people, this is a stigmatizing term. And oftentimes when we're working on bills, we're weighing, should we not? And particularly in this bill, S27, myself personally, I was kind of morally weighing what is more stigmatizing, medical debt and having, you talked about why someone needs to go through the onerous process of proving the type of care that they were receiving with using the term. And it's often this, you know, competing. And so I had conversations with Representative Donahue and asked if she would work on language to help us. You know, we have our guiding principles behind us, and I've often said that sometimes our guiding principles conflict with each other. And I really felt strongly that, you know, maybe this would help in those times when we have bills in front of us and we have to make this decision, and our moral compass has conflicts. And so I was proud to sign on to this. So thank you for allowing me to co-sponsor with you.
And I thank you for the, working together at finding a solution, threading that needle.
Leslie.
I think this is an amazing solution and I really appreciate it. I think I come from it in a very simplistic way, which I will admit I have experience in my life where someone would come in and they would be drinking 2 liters of Mountain Dew a day. That's behavior.
Mm-hmm.
They had diabetes.
Mm-hmm.
They stopped their 2 liters and their diabetes went away.
That actually is one of the examples I give in my comments, my intended comments.
Yeah, so I really appreciate that there are behaviors, unfortunately, that we do that make us sick, that we then can address. So I really appreciate the work that you did. Yes.
Thank you. Any other questions or comments? I will do a straw poll on whether or not we find, oh, Daisy, I see your hand up.
I apologize for not being in the room right now. I'm parking my car. Thank you for working on this. It's a really thoughtful amendment and something that is contributing to an important conversation in our field and in our policy of the state. It's something that I would love to continue the conversation about. And I think it reflects decades of Representative Donahue's efforts to advocate for equity for folks like us who are living with mental health challenges. However, I do not think that for myself, someone with a mental health challenge and someone who has worked in this field of mental health and substance use for decades, both as someone who has worked at provider member organizations, who has worked implementing programs in all 50 states. I don't think I can support the amendment because I don't think that it is fair to say that it reflects my personal intent with regard to how I use the term. I do agree that it is a stigmatizing term. However, when I use the term, I really want to be sure that it is a way to meet everyone who is working across our entire healthcare system to create a holistic and integrated system of care. And sometimes that means using language that is adopted by other folks, such as our payers, so that they can give us as Tom Insel says, the rigors of other disciplines in the healthcare system, because here we are advocating as folks with mental health issues for equity and payment parity and access. And I think we need to leave open that option. And I see that the language has attempted to do that, but I believe that we need more conversation around this definition that is inclusive with Vermont providers and the broader community to shape a definition that is reflective of all of their experiences. But thank you so much for working on this.
Thank you. Thank you, Daisy. Anne, did you?
Just, I don't, you know, I don't want to engage in that conversation now because it's not the place or time. I will give more of an explanation on the floor about why many clinicians and many, not all, but many folks in the community of people with lived experience, why it's actually a barrier to parity and from that perception. So, you know, there aren't the same perspectives, but if one group feels it's very harmful and another feels it's not, I think we need to pay regard to those who feel it's really harmful. And there are, you know, a lot of clinicians who feel the same way. When I had to fill, you know, you go for your annual physical, you get the form that says, okay, answer this behavioral health form, which I refused to answer. And I went in for my appointment. It was actually a new primary care. My doctor had retired, and he said, "You didn't fill out your form here." And I said, "No, I won't fill out something that is offensive and stigmatizes me." And he said, "Oh, I agree with you totally. It's really inappropriate. I can't control it because it's something from, you know, on high, but completely support you on that." So anyway, it's.
Thank you. And I hope we do continue the conversation. I don't believe that this amendment is the end of this conversation. Daisy, it's a stark reminder that we're elected to be here for our constituents, and always our conscience is next. So thank you for following your conscience on this. Any other comments before we?
I support it. for what it's worth.
Okay, we're gonna do a straw poll, so.
Okay.
You can do either a verbal eye or a little emoji hand up.
I could put
So-
the camera on for a second. I just couldn't get there exactly on time. So.
That's okay. All in favor of, I never know how to word this, finding this amendment favorable, please raise your hand. So 9, and all those who find the amendment unfavorable.
Are you in unfavorable?
Yeah.
Okay, so it's
And Daisy has her hand raised as well.
Yeah, he's
or 8-2.
9,
9-2.
9-2. I can't add either.
It's too early.
Thank you.
Thank you very much.
Look forward to hearing you on the floor. Yeah, are we all? No, don't be on the other.
Thanks for checking.
Yeah. Then
One more amendment to do. Thanks, Representative Donahue.
Thank you.
Representative North, would you like to come on? Tell us about your amendment, and we have Ledge Council with us as well, in case we have any questions about that.
Great. Well, thank you, committee, for allowing me to come in and just explain this, what I think is a very simple amendment. Thank you, Madam Chair, for allowing me to come in. So amendment to S27, and my target here actually aligns very nicely with the third bullet on your guiding principles there, empowering people to participate in their own healthcare to the best of their capacity. And that's fully what I'm trying to accomplish here with this very small amendment. And it is to encourage us to, as we go forward with this debt relief, which I think is a great idea, to do it with people who are of the greatest need. So So the very first item within the amendment is just reducing the eligibility spectrum of folks to which this would apply from what's currently stated as 400% of the federal poverty level down to 300% of the federal poverty level. So just reducing the eligibility requirement for those at the upper end of that scale. It turns out that based on the 2025 numbers, 400% of the federal poverty level for a family of three equates to earning about $104,000 a year, which seems a little generous. Folks maybe in that category may not need the aid that this bill is trying to provide. And maybe we could skinny that down to 300%, again, working toward empowering people to participate. So encouraging participation in their own healthcare to the best of their capacity. And then the second one, although it takes a lot of page and verbiage, really just boils down to the one sentence, which is under item C, paragraph 2, which is just the one sentence, that the debtor has demonstrated a consistent good faith effort to make payments on the medical debt. So it's really just those two simple things, reducing the eligibility spectrum down from 400% down to 300% of the federal poverty level, get us down from the $104,000 a year down to the a little less than $80,000 a year range, folks in that income level, and then ensuring that the folks whom we're helping have not been just sitting back waiting for the state to help them out, doing nothing, but folks who are, made a good faith effort to try to pay off their debt. And so that's really the sum total of what I'm offering as an amendment.
I'd like to take the second one first.
Sure.
Can you describe what you mean by a good faith effort?
Yeah, that's a standard legal term, good faith effort. And I would expect the courts to be able to adjudicate that according to the way they normally adjudicate the term good faith effort. I'm sure the Ledge Counsel in the room could probably clarify that for us more than I could, and I'm not a lawyer, but I know it's a standard term.
So,
So can I give an example? For example, what I would expect is that somebody who has been making a good faith effort has at least been making some minimal monthly payment. Maybe it's only $10 a month or a dollar a month, just that they've made some effort to stay engaged with this debt that they personally incurred per the third bullet. That this is their own healthcare and they should be participating in that to the best of their capacity.
would a good faith effort be 2 payments?
I would leave that up to the judge to decide. I don't know.
Can I insert a question?
Sure.
I'm confused. Are you intending that for anyone who's having medical debt paid off through this nonprofit undue medical debt, that each and every write-off go through the court system?
I don't know how it gets adjudicated. That's not specified here, so I don't really.
Okay, I'm sorry.
Or if it were,
Sorry,
if it were challenged, it would be on the court system. I mean, I don't know that that's necessarily the mechanism that would be employed.
Right?
Yeah, so I just want to remind folks that how the process works in this type of situation is that, and it says in here that the healthcare provider has completed its routine efforts to collect the amounts due. And so normally they would probably already be in a collection agency or they've already done all the work. And how something like this, and I believe we heard this testimony, but also as a reminder, I worked for a credit reporting agency for a long time. It's all electronic. And so undue medical debt would be like, hey, these are the criteria of the type of people that we will buy the debt from. And that is electronically all done. So nothing will go before a judge. Company will buy that debt at a penny or whatever it will be, and that's the end of it.
Woody?
I like the idea of individuals trying to pay off their debt, but I think we have to give some leeway to the treasurer in hiring or contracting with the nonprofit that will be managing this. And I think the treasurer does have an idea who he would like to contract with. And that'll be up to the contractor that has a great deal of experience. I don't know personally, but I'm assuming that they will be looking into that sort of thing. It's an assumption, I know.
Right.
But that's my thought on that.
Topper apparently didn't finish. I'm so sorry.
Sorry.
That happens all the time.
I know, sorry.
Let me just,
Oh, Brian has one too. Go ahead. Sorry, I'm.
you're making me lose my train of thought.
Okay.
Here's how I look at that, just from my point of view. A person who is destitute and has an income at the poverty level, not 400%, but at the poverty level, may not be able to do that, what you're talking about, a good faith effort. Whereas somebody else may be able to make a payment or two, and then all of a sudden, they can't make it anymore. So I think when we start setting up those kinds of restrictions, not only are we restricting the person from 300 to 400,000, but we're also restricting the lower end of the scale. So for that reason, I can't support that part of your amendment. Now, the other part, can you just go over that first part again? The reason why you want to go to 4 to 3?
Just to bring it more in line with the folks who most need the aid. The folks at the upper end of that scale, it would provide more funding available for the folks who really need it. I guess was the way. Let's focus on the folks who really need it, I guess was my thought.
And if those folks that really need it down the bottom, if they can't do it, they can't get it either because of your Second Amendment.
Because of the second one.
Yeah.
That's fair. Point. Absolutely fair. Point.
Yeah. And to me, I think I mentioned this before. When you got a working family, let's say the wife, both partners, one's making 40,000, which is in the poverty range, and one's making 50,000. So that together they're making 90,000, and they got a kid or 2 kids, and they have this catastrophic thing happen. They may be okay. When the catastrophe hits, now they're not okay. If somebody's making $80,000 or $90,000 and they get hit with a $30,000 or more, or in that area hospital bill, they can't pay that unless they got a trust fund someplace. So I think when we start restricting who's eligible for this thing, we thought this over. We tried to include working people because they need it as much as an individual who can't work. So that's my point.
Alan,
Yes.
the changes that. Were you all set, Topper?
I'm done.
Okay, yeah, Brian has a question.
Go ahead, Brian.
Wait, hold on.
Took out the monetary limitation. I still.
Do you want to break, Jen?
Did we take a break?